So I'd like to talk about iris lumps and bumps. So I see quite a few of these at the hospital. The referrals end up usually with Mark Elder or myself, and we cut a few out and also enjoy fixing the resulting holes in the iris. And some irises have holes already from trauma and various other things, so that's what I'm going to talk about. We do get a lot of referrals with it. Could this be a melanoma? What do we do with this cyst? They're really common little bumps on the iris, and Caucasians with light irises, 50% of us have iris freckles, so that's a lot of people, and 4% have nevi. And a recent study from Australia finally showed, which you'd probably think is sensible, since it's usually light-skinned people who have light-coloured irides, that there's a 1.5 times risk of melanoma if you've got more than 3 pigmented lesions on your iris, or 3 or more. These things have ocular associations, so if you see a nevus, there's an increased risk of uveal melanoma. You don't want to miss a melanoma, is probably the main reason most people are here. And then I just wanted to discuss a few of the things that I enjoy doing to irises. So I'm going to be reasonably didactic, I'm afraid, just going through and looking at things that could or couldn't be melanoma for a start, then some cysts, and then talking about some prostheses and other suture sort of fixes for irises. I'd like to acknowledge where most of my information is from tonight, which is from Shields and Shields, who published really the only series which is 3,700 cases of iris tumours. So there's basically 0 or 3,700. There's not much in the literature. And then there's quite recent reviews from the American Academy 2018 on solid lesions and cysts, and a few other sources as well. So that's the plan, and I promised some photos. So it's a cat with heterochromia, and it comes into play a bit later. So there's various types of pigmented lesions, and Shields and Shields list these lesions. Freckle not being listed by some people, but freckle you can certainly see as a separate than to a nevus in the eye. Melanocytoma, melanocytosis, which have systemic associations, and of course melanoma. So what's a freckle? What's the definition of a freckle? Essentially it's flat. It's usually both eyes, usually people with blue or green irides, and it's not a mass, so it's pretty flat. And I think you'll agree those sort of flecks on those two pictures there would be freckles and not nevi. Briefly want to mention lesion nodules. So we sometimes get asked to see people with neurofibromatosis just to confirm any ocular features. So lesion nodules, you may see they're pretty much universal in people with neurofibromatosis. If you see someone with them, it's very likely they have neurofibromatosis type 1, so that has systemic implications and they should get screened. The key thing about lesion nodules is that they're sort of tan colour. So they're tan colour even if you've got brown, dark brown iris or blue or green iris. They're about 1 millimetre, they have little seeds around them, and they don't really look like anything else, so they're pretty classic. And they don't turn into melanoma. So if you see it, you can be pretty confident you don't really need to follow that up, but just make sure they've got some medical follow through for NF1. So this neurofibromatosis type 1, you see these cafe au lait spots on the skin, so more than 6 is part of the diagnosis. And it can be associated with the nevus. Was that the wrong slide there? That's a, quote, bag of worms, plexiform neurofibroma of the eyelid. So in the eye clinic, this is a great exam question. What's this? What do you do about it? They're sort of disfiguring, but they can also absolutely obscure the pupil and need resection. and it's quite tricky. There's sort of bundles associated with the nerves and little tumours along nerves. And as these guys get older, so it's a hereditary condition, chromosome 17, they get more and more of these neurofibromas on the skin, but under the skin as well. It can be reasonably disfiguring for some of them. They tend to be a bit shorter, have slightly bigger heads than other people, but sometimes you really can't tell. They're sort of normal spectrum and range like anything else. They have some health risks, cardiovascular risks, breast cancer, some GI cancers, but really they do have a normal life expectancy. But they need to be checked out. So what's then is an iris nevus? How's that different from a freckle? Well, they're bigger and they've got a thickness, and they actually invade into the stroma, so they start to distort the architecture of the iris. So that can result in ectropia and UV, in a peaked pupil shape, and we start to get into these features. Is it a melanoma? If you've got distortion of pupil, they can be quite big, tend to be 3 millimeters plus or minus. They can be quite diffuse or flat as well, and they'd still be called a nevus if they're large. And I've got a picture of the iris nevus syndrome, which is part of the ICE syndrome unilateral. The Shields and Shields crew suggest that people with an iris nevus should have a yearly examination and be dilated because it's about a 4% risk, I believe, of having a uveal pigmented lesion. So that's reasonable and worth routine exam. So these are nevi. You can just see a sort of typical appearance. You sort of think, is that a freckle? Nah, it's too big. It's probably got a wee bit of thickness to it. Likewise with this one, just starting to distort the pupil a wee bit. And this is a diffuse, really the whole surface of the iris in this case is unusual, a bit pigmented, slightly thickened. To me it's a different beast, but it's a diffuse iris nevus and iris nevus syndrome, so ICE syndrome, associated with distortion of the pupil, and they may also have increased risk of glaucoma, etc. Melanocytoma, this is pretty rare in the iris. So optic disc melanocytoma is something that possibly some or all of us may have seen. Again, it's reasonably rare, but that's the classic description. It's almost too uniform, too dark brown. It's a real dark chocolate colour to be a melanoma. And you start to look at it with the size, something this big, you're going to have to check it out though and be pretty conservative in thinking this is not a melanoma. However, you might, if you think about it, think, oh, this looks like a melanocytoma, you might do something a bit more conservative, like a fine needle biopsy rather than cutting the whole thing out if you're worried about a melanoma. They're associated with lots of bad things, raised eye pressure, seeding into the angle, and also little seeds around on the surface of the iris. So melanocytosis is different yet again, and the key to this one is that there's scleral pigment. So the pigment's actually on the sclera or immediately episcleral. So the conj will move over the top of it, and the pigment's deeper. And if you get that, you can be 100% sure it's melanocytosis. And it's one of the causes of heterochromia. So in this case, it would be affecting the darker pupil, sort of extra pigmentation deposited throughout the eye and the sclera and also in the fundus. The iris characteristics, melanocytosis, is a little mammillation. So I haven't got a picture of that, but sort of micro brown dots across the surface. They're not necessarily melanocytosis, but in melanocytosis you tend to get those mammillations. Important association is if there's pigment around the eyes on the skin as well, and sometimes whole side of the face, etc. And then that's called oculodermal melanocytosis. It's known as a nevus of Ota, and that has some implications in terms of a risk of meningeal melanoma, as well as in the uvea and in the orbit. So they need scan, if you see that. So how do we tell what's an iris melanoma? They're bigger. They may have blood vessels on the surface or intrinsic within them. Tend to present a bit younger, so if you see a 40-something or a 30-something or a 50-something, you start to get a little lower threshold for investigating, referring to another colleague primarily. And the same things that a large nevus will do, distort the pupil, ectropia and UVA, etc., and you can even get cataract with them. If they're starting to invade through the sclera or bulge into the ciliary body, that's different. You kind of know something's not right and you need to investigate. So iris melanoma is only 3% of ocular melanoma, so much more common to have choroidal melanoma, and ciliary body's pretty rare as well. The key that I've seen with this, and I've cut out a couple of them, and I've helped Mark looked at one and Liz Connor as well, done some shared cases. All the ones we've done have been pretty benign and really borderline. So we sent them to pathology and they said, we don't know if it's a nevus or a melanoma. And then they have to send it to Sydney and then to the United States to do special markers. And eventually they come back and say, oh, yes, it is a melanoma, but it's kind of a really mild one. And then we'll talk to Peter Haddon in Auckland, who's the New Zealand ocular oncologist. And we'll go, Peter, what do we do? And we'll just go, I'll leave it alone. So this has been my experience with a handful of iris melanomas. And the other ones, the eye's been taken out before I've got to them, basically. And it's quite personal, so you need to talk to the patient. So this could be a melanoma. Do you want us to just cut it out locally? Do you just want to be safe and take the whole eye out? And some people actually want that. Most younger people that I've had to deal with don't. They said, no, doc, what's the risk? I want to be able to have two eyes and enjoy my life even if it's 10 years. So you get into quite serious sort of conversations. And there's a risk in whatever you do, essentially. The data would suggest that compared to skin melanoma, which has a very high rate of this isn't spread within 10 years, it's only 5% of iris melanomas have metastasised essentially at 10 years. So they seem to be a little bit of a different beast, and whether they're picked up earlier because it's sitting on your eye and you can see it, I don't really know, but they seem to have a different histology, so different cells. Yeah.
John, does that suggest it doesn't metastasise quite as aggressively? Or?
Definitely, yeah. So exactly that. They don't metastasise as much, and they on histological examination they are slightly different. So the cells are less aggressive, less mitoses. Why that should be in the iris instead of further back in the uvea, don't know. But they still can be nasty. Yeah. So the shields have a thing A, B, C, D, E, F. It's another one. And they did a massive study, and this is the associations that they found with what nevi features were likely to turn into melanomas. So strangely, they found younger people were more likely. When I say younger, they had a random cutoff, less than 40 or over 40. And that was based on the fact that uveal melanomas tended to be in the older age group, 50s and 60s, to be melanoma. So they were somewhat surprised to find a little bit younger. Blood in the AC, well, to me that includes blood vessels. Obviously any bleeding is a real risk factor for tumour. It's abnormal cells. Inferior position, again, don't know why, but maybe more sun exposure in that location. That so-called diffuse configuration, so nevi that are kind of flat and spread out, not well defined, tend to be higher risk. Ectropion, that's ectropion UVA, so distortion, and then feathery margin, so when you can't quite see, it's not well defined, is it growing, don't know. So that's the A, B, C, D, E, F. And some of these pictures have multiple, so that's sort of got blood. It's not actually pigmented, but melanomas don't have to be pigmented in the eye. Majority of them are. This is sort of inferior location, pupil distortion, ectropion UVA. This is sort of feathery margins around there as well as ectropion UVA. So there's some sort of dodgy looking nevi. Got any questions about pigmented lesions before we move on? No. I said it was quite didactic, so apologies. It's not very case-based, we'll get to that. Surprisingly, again, there's not that many non-pigmented things on the iris to sort of worry too much about. So people with Down syndrome tend to have these little white dots around what you call brush field spots. So if you see them, they're benign. It's just really an association. Don't know what they are. Metastases. It looks abnormal. It's a palish, could be pink, yellow bump, vascular, often with blood. I think when you see metastases, unless it's really at the first stages, you'll be suspicious about it and need to refer that and go looking for a primary, which is often breast or lung as well. You can get smooth muscle tumours on the surface of the eye from the muscles of the iris. You can get gland tumours of the pigment epithelium, and you can get xanthogranulomas as well, typically with people who have them on the skin as well. It's quite important, what do you do about it? So the first thing is documentation. It's really important to, if you can these days, get a photo, image it, and I think most of us will have the ability to do that or send it to someone who does. But at least measurement, documentation. The next type of investigation, so when they end up here or at the hospital, we're going to try and get an OCT, see if we can see, is it cystic? Is there fluid in behind the pigment, in behind the stroma of the iris? Is it solid? Is it consistent? Where is it? Does it go into the ciliary body? And that's the main test that we'll be doing, trying to image it. And ultrasound is probably slightly better than OCT because it penetrates. OCT, when you get behind the iris, it's sort of in shadow quite often. And some machines are worse or better than others at getting the anterior segment imaged as well. Have a lot of patients that we're just following, and you're a little bit nervous, so say, oh, we'll just see you really soon, another 12 weeks. And if it's changing, then I'll probably ask a friend, so Liz or Mark. So can you have a look at this? What do you think? Should we ask Peter? And so get more people involved. But more often than not, you have a history. Oh, there's a photo when they were 15, it hasn't changed. Or, okay, I've already seen you 9 months, it hasn't changed. So you can start to relax at that stage. Interestingly, Peter is quite often in Christchurch, and his son is in my son's soccer team, and his other son, so his kids go to school here. So he's down all the time for a little sideline consultations, which is quite good. So when you do get a lump that you think, this could be melanoma, what do we do about it? And there's a whole nother discussion, because If you cut it out, if it's on the iris and it's not extending into the angle, you can just cut it out very carefully without trying to seed it. So there's various techniques to sort of cut it out, roll it up, suck it out without spreading little bits of it all around the eye. If it goes into the angle, then you need to cut out a bit of the ciliary body as well as the iris, and then you're cutting out zonules, and then you can't get much margin. It can't really be bigger than that, because that doesn't have zonules from about there to there. So the lens is sitting in behind, you can't see it, and it's just hanging on by the remaining 2/3 of zonules. So beyond that, it's radiotherapy, so usually a plaque, but you can use a beam, but it's not as good. So they'll stitch a radioactive little, looks like sort of a, I don't know, like a dime or something onto the eye for a period of maybe 24 hours, depends what dose you want, and then take it off. And that way you get to keep the eye, or you can take the eye out. So on that happy note, I just want to talk briefly about cystic lesions. So we know that the iris has got two layers. There's the stroma in the front and the pigment epithelium, which is a double layer on the back. So basically cysts can occur in either of those layers. The pigment epithelial is just way more common, and you quite often just see a lump underneath the iris, and that can be up by the border. You can even see a little black cyst peeking around the corner. It can sort of just be a bulge in the mid-region or towards the angle. You can get a cyst in the stroma, and that's quite distinctive, so it's really thin-walled. There's some pictures in a minute. And you can also get cysts caused by trauma or surgery, where either the corneal or the conjunctival epithelium's gotten where it shouldn't and starts growing. And it's a big problem. It happens. Yeah. So there's a picture here of just peeking underneath the iris, and there's a big cyst, basically a bulge in between the layers of pigment epithelium and the iris. And it's just fluid filled. Usually doesn't cause any trouble unless it's really big, squishing the angle closed, and can usually just be observed. This is pretty large cysts all around the pupil margin, and that might be starting to affect the vision, so might need something done about it. And again, we just confirm that these are cystic, and if you get a picture on an ultrasound of a nice gap in the middle, then you can pretty much be sure, it's not a tumour, it's a cyst, it's benign. So I've got a picture of an iris stromal cyst, and they most often show up in kids. It's the reverse. They usually need something done about it because they cause trouble. They either squish the cornea, or they squish the angle, or they do something. So this here is the cyst. And it's kind of a translucent surface where the front surface of the iris is kind of split and bulging forward, so really different to the pigment epithelial cyst. And I suspect if that came to your clinic, you'd be sending it somewhere anyway. It's like, I can't see, you'd better go somewhere else. So I've had a couple of experiences with epithelial, quote, downgrowth. So with LASIK flaps, you get ingrowth. Well, if it's in the eye, it's typically called downgrowth, and it can be really nasty. I had an experience when I was learning in Australia with a very senior corneal surgeon who had inherited it or been sent it from elsewhere where they hadn't been able to get it all. And we ended up losing the eye, basically. Put all these toxins in there, tried to scrape it all out. And if you don't get all the bits of epithelium out from inside the eye, it'll just regrow. So it can be really nasty. There are several techniques described for getting it out without that result, although personally I've never had to do a case. So I'd certainly try less invasive methods, but apparently you can cut them out, but you have to cut them out whole. So don't leave cells behind. You can laser stuff that's left behind, and you can use alcohol inside the eye. Alcohol is super toxic, obviously, to the epithelium, just falls off if you put alcohol on it. And internally in the eye, it's pretty toxic as well. So you have to kind of protect the rest of it and just get the alcohol in the cyst. Having said that, it's not from personal experience, just for one of you reading. So, yeah. So we don't see this so much, but I don't know if many of you have got patients on long-term pilocarpine. So it used to be super common with glaucoma. It was one of the only agents we had. It sort of was like adrenaline, pilocarpine, timolol sort of. But apparently quite a few of them used to get these little irises. There may be the odd older patient with those. Very benign and just a feature. This is a picture of epithelial downgrowth, and it's come from the graft, corneal graft margin. So apposition of graft and host, and the skin cells have got under and survived and gone and grown and formed this thing filling up the eye. So not ideal. Yeah, so that's my end of my didactic talk, hopefully on lumps and bumps on the iris. I've got a few cases, and this is something that I really enjoy because there's so many different techniques, and you can get it wrong for 5 years and then suddenly find out, oh, there's a better way to do it. And I've had some quite good experiences in the last few years with making really big improvements to people just by putting a stitch or two in their iris, or a certain prosthesis that works without doing silly things to the eye. So this was a guy who did quite recently. He had originally had a complicated cataract with really high pressure afterwards. Had some sort of traumatic mydriasis, but it was probably through really high pressure after the cataract surgery in the 24 hours afterwards. And subsequently dislocated the whole lens and bag, so it's sort of falling down. And Sean had removed that and replaced it with a scleral fixated Yamane style intraocular lens. However, he still had the pupil very oblong and dilated out on one side, so it was really light sensitive. Couldn't really get the greatest acuity, maybe 612 out of the eye. So he sent him to me, and unfortunately I don't have a colour photo, but this is just a retro illumination, and you can just see there's a sort of crescent. This is not dilated, this is just how the eye is, around the edge of the lens, and he's going to be getting a lot of glare and rubbish through there. So this is readily amenable to just some simple stitches. So there's 1, 2, 3 stitches, just sort of cobble it together, there to there, there to there, there to there, and that is able very simply and good long-term result to cover that edge of the lens. There's quite a lot of people out there with this sort of pupil, I would say. I mean, or in my clinic, maybe not in your clinics every day. So I'm, very, very confident to say to people you'll get a pretty good result, usually with something of that nature. Now,
Like dilate muscle and stuff. Does it still?
yeah. Well, these ones are damaged, so it's less of an issue. It's pretty, not much is happening with that iris. So it's kind of safe from pulling on your stitches too much. But that can be a problem with other ones that I've done in the past. So we live and learn. This is a pretty interesting case. This is actually from the Pentacam. I haven't got a photo of him, but I don't know if you can make it. There's a little aperture there. So that's a hole, and all of this is a black sulcus lens, which is a pinhole sulcus lens. So he has got a pretty dodgy eye. So he's had trauma, I think it was a nail, and then he's had a cataract with not many zonules around there, and vitreous, and his cornea was decompensated, and it's paper thin up here, and he's actually got a DSET graft, and he couldn't see that well. And so I thought, oh no, what am I going to do? So, and the edge of the lens is somewhere about here. So I was getting light through it, distortion, and really poor acuity. So Morcha, who stopped making a lot of things lately, still make this, and this is a new thing they make, which is a sulcus, really flexible pinhole. It's only 1.3 millimeter aperture, and you can just stick that in there, and it has a pinhole effect, but in the right place. And this guy's not too bad. He's sort of 624, 618. The VR surgeons don't like it. Imagine if you're trying to do a retinal detachment through this. So let's not go there, but they would probably have to take it out in order to fix it, and it's pretty flexy and will come out okay. The cool thing about these is you can OCT through them. So we're trying to look in clinic. He lives on the west coast, this guy. You can see through it, but not great. But you can get a perfect OCT through it, because the infrared will go straight through it. And a lot of these sort of pinhole lenses that are out there now, if you're struggling to see, try the OCT, because you'll get an image and you can do your normal OCT scan through it. So that's pretty cool. So this guy was a patient, had come down from Auckland, he moved to Christchurch, and had been planned by Charles, the big boss of cornea in New Zealand, to do an operation. He had a dislocating lens inside here, and this was something versus eye, penetrating injury, and torn out the iris, so iris is missing, and lens dislocating in there. So the plan was to use a Morcha lens, which has an aniridia, blackout edges, remove the lens that's falling down and put the Morcha lens in, either in the sulcus or sutured or in the bag if possible. However, coming onto the market and coming available in New Zealand is an artificial iris which is hydrophobic and includes a lens. And this is it. So it's made by Reaper, and unfortunately it's from Russia. So I don't feel comfortable using them just at the moment, but this is the first one put in New Zealand. So this is this guy, and we removed his lens and put this lens in, and they come in there's a colour, a swatch like for carpet or curtains, and you literally just put it up against the other eye or get a photo and go, oh yeah, that's the colour, and then you order colour 28A and the lens you want. And so this has got an optic in there as well, and it's a hydrophobic acrylic, so like the other intraocular lenses that you can get nowadays. So I thought, yep, that sounds pretty good. The previous artificial irises are made of silicone and other things which haven't got a great track record. Can cause inflammation and things, so I'd been kind of avoiding using those. But at this stage, sort of, still got his stitches in, I was pretty happy with this, and yeah, he's got a corneal scar and he can't see great, but he was around 624, 630, and he's 6'6" in the other eye, and he's happy. And with this sort of eye, if you can avoid a corneal transplant and all the inherent risks with that, I prefer not to, so I was reasonably happy with that. The beauty of having this lens in there is you could still do a corneal transplant. You've got a spherical intraocular lens and you can just stick a transplant in there. So this is him before and after. I've done something funny with the filters, so his skin looks orange on this one, but it is the same guy. And cosmetically, he's not getting so many looks, maybe not a second look, whereas before always was. Unfortunately, he has got a little bit of inflammation in that eye, so he's got a requirement for fluoromethalone at the moment. He's several months down the track, so I'm still not sure. But it's well managed with that, but still not perfect. And I wonder if it's because the iris is rubbing on it, or just don't know. So this is the older artificial iris. You can still get this. It's what they do is you take a photo, and then they will make one the colour for you. They're about $6,000. 0.1 millimetres thick and 12 millimetres across. But ACC will pay for this if you have a patient. But personally, I haven't been that keen because they're silicone and they don't have a lens in it, etc. But it's the alternative that is out there. This is another relatively simple thing you can do with stitching. So if people have got iris root dialysis, like this guy or this guy, you can stitch it back, and it's relatively straightforward and super satisfying. So if you've got any patients like that who are getting glare and stuff, there is something you can do about it, and it's reasonably simple. And the last one, which I was super keen on, and based on Roberta's question, maybe not quite so keen anymore. So doing people who still have muscles, and you're putting a stitch using a needle, you can come from the outside of the eye, take a couple of bites, come out, then go back in, take a few bites, come out, go back in, take a few bites, and you get a stitch that's sitting around here, and you tie it up like a shoestring, essentially, and that'll bring the pupil from being really widely dilated in a traumatic mydriasis or somewhere where it's not pulling, it's still relaxed, you can get it to cinch down, and you want the pupil surprisingly small. So this is probably a bit, it's okay, but anyway, it's hard to get it relatively small. And what I've found is people have done a few of these, and when they've come back and they've been dilated by staff when they arrive, and it's like, because the stitches in the middle and the bits of iris is sort of pulling off it, and they're still good though when they come back down so far, fingers crossed. So I'm more keen on the simple stitching now, but we'll see. Yeah, it's not elastic. Yeah, elastic would be useful. And there's a whole lot of other devices. Now, interestingly, Morcha has stopped making all of these. So, but there's companies in India that are now make pretty much anything you want. So I know that Jim got a completely opaque lens a couple of months back, and they will make pretty much whatever you want. So these capsular tension ring with little sectors of occlusion, you may have seen some cases with these, and they're a little bit old style, but they work really well. Cosmetically not so great, but it does the job, and lots of people don't care too much about the cosmesis. So you put one in, and you put the other one on top of it, and then rotate them so that the little flanges overlap and make a complete occlusion. And there's various sizes with small little flanges to big flanges. They're much harder to get in. There's also these sorts of capsular tension rings, so they go inside the bag with the lens. You can put it under it or on top of the lens. So that would be, say, a 50% loss of iris. You can stick that in and do really well, cut out the light anyway. But cosmetically not as good as those fancy ones, but they probably work better and are simpler. Yeah. That's the end. So thank you very much for coming, and hope it wasn't too boring and didactic. Yeah. Cool. Any questions? Yeah. Thank you. Yeah. Right. Eat, drink, and be merry.